Hello everyone, I'm here to talk about my behavior project for this semester. The title of my project was Increasing Imitative Repertoire by Teaching to Imitate Pointing at People or Objects. I decided to focus on this behavior specifically because it is known that children with autism spectrum disorder often have difficulties with joint attention, and specifically associating words to an object via a speaker's gaze. Research in this area has shown that this could be caused by their performance with gaze duration on an object, and it can improve when this object becomes more noticeable, which can be done by pointing as one method. To look into research in this topic, I looked at a study done in 2013 by Akichi, Kikuchi, Tojo, Osani, and Hazawaga. They explored this topic and hypothesized that adding another speaker's cue, such as pointing, will improve the performance of children with ASD. This would suggest that adding additional speaker's cues would help with word learning in children with ASD, which is what they were specifically focusing on. The results from their study supported their hypothesis, and they did have positive outcomes for the children involved in the study. Another study was done using very similar techniques in 2004 by Akamungo and Batu. They focus on teaching pointing to their children as well, and they specifically taught them the skill to point to numbers using simultaneous prompting. All children in this study were formally diagnosed with autism spectrum disorder, and the results of their study suggested that the simultaneous prompting was effective in teaching this skill to their participants. Another study that I thought would be helpful in learning more about this subject was done by Gans, Bourgeoisie, and Flores in 2008. This focuses more on imitation and training with children with autism spectrum disorders and other developmental delays. Imitation skills are essential to a child in their academic and their social settings, and it carries over into socialization, observing peers, and learning from their peers' actions. This study looked specifically at 4 participants who were all formally diagnosed with autism or PDD-NOS. They participated in 6 sessions designed around small group activities such as modeling dough and other arts and crafts. For the intervention in this study, the children were instructed to imitate their leaders' actions. 3 of the 4 participants did show an increase in imitation behaviors as a result of an implementation of visually cued imitation training. So the positive results in this study did suggest that motivation and a stable background in which to look at pointing, visual cues, and imitation can all be used as learning tools for teaching a child with autism to imitate a specific action. So when I was looking at my study, the purpose of my study was to look at the method of imitation and prompting to explore its role in increasing a child with autism's abilities to independently imitate his therapist's action. So my participant or client in my study was a 5-year-old boy formally diagnosed with autism at the age of 2. He currently receives 37.5 hours per week of applied behavior analysis therapy at an outpatient center. He is there from 8 to 4:30 Monday through Friday, besides 1 hour a week where he attends speech therapy. His sessions are consisting of one-on-one with 2 different therapists a day. He has one in the morning and one at night. He has a home base where he spends most of the time during the day, but he also has access to other rooms within the building. But most of his therapy is done in his home base, where he has his own specific workstation where we are targeting to get him to sit at longer and longer to look closer to a school setting. The current key focus of his program is to increase his functional communication through having him learn sign language while also encouraging vocalizations. His program is structured around increasing age-appropriate socialization, visual perception, and listener response skills. He often struggles with making transitions, peer interactions, including eye contact, and he is an elopement risk. So for my project, the specific definition for my behavior was imitating pointing at people or objects is defined as pointing at the same person or object that was pointed at by the provider. Pointing specifically was defined as extending a finger in a specific direction towards an identified object or person. So an example of this would be if the provider or therapist were to point at a person, the client would imitate this action and point at the same person as well. Another example would be if the provider points to a yellow crayon amongst 3 other crayons, the child would point at that specific crayon. Okay. A non-example of this would be if the provider were to point to a picture on the wall and the child would not respond at all or would point at a different picture in a different location. So in order to keep data on the number of occurrences in which my client would imitate his therapist, I used frequency data. The total number of opportunities that Chris had to be successful were also recorded. So at the end of each session, the number of correct responses are recorded. For example, 8 out of 10 correct, or an example would be he had 2 out of 10 possible opportunities correct for this session. The numbers were then converted into percentages by multiplying both numbers by 10. This final number at the end of each session and at the end of the entire project provided me with the correct number of responses out of the total number of opportunities for each session that was conducted. My client's program manager and I held a formal meeting prior to gathering the baseline data in order to discuss the proper data collection procedures. His program manager observed and recorded IOA data 10% of each of the sessions of each phase. These occurred during my breaks throughout the day when it was the program manager's role to relieve me. IOA was calculated using trial by trial and was recorded the same way as the data as a percentage out of 100. For my project, I had a total of 100% percentage for treatment fidelity. So for the procedure, I used a single ABA design. This was so I could look at the baseline data and see where he was before the intervention, how much he improved during the intervention, and I wanted to go back to remove the intervention to see kind of a maintenance data where he was at that point. There was 5 sessions for the baseline data, 5 for the treatment, and also 5 for the return to the baseline. During this entire project, I and his program manager were the only 2 involved, and we did not change his schedule. Everything stayed consistent. I did take maintenance data 2 weeks after the conclusion of the assessment, and for the maintenance phase, the data was taken during the afternoon sessions. During the baseline phase, I and his program manager did our best to not alter his routine, besides setting aside 30 minutes during each session for data collection. And frequency was taken during this time. The baseline data consisted of no prompts. I only pointed at a specific person or object to bring attention to it, and then recorded whether or not my client imitated this action and did the same. For the intervention phase, I established instructional control before beginning treatment. After a preference assessment was conducted and preferred items were placed in close proximity of the client and the therapist, I made sure that there were minimal to no environmental distractions, such as loud noises, because he does have an aversion to loud noises. Just anything in the environment that would be an extraneous variable for my results. So the preference assessment was made at the beginning of each session to ensure that we had positive reinforcers that would motivate him to make the correct response. So when Chris would make an incorrect response, I or his program manager, whichever was working with him at the time, would implement the most intrusive prompt on the hierarchy of prompts. In this case, it would start with a full physical, and that would consist of me picking his hand up, extending his finger, and pointing it in the correct direction. If he did not respond to my SD at all, this was counted as an incorrect response, and the same steps were followed. A withdrawal of the intervention procedures was implemented, and the maintenance session was conducted. In order to provide opportunities for generalization, Chris performed this task in many different rooms throughout the building with many different people and objects. Generalization was also practiced by having both his therapist and his programmer run trials, so it wasn't just me for the whole time. Okay, so the results of my study showed that during baseline, my client correctly imitated me pointing to specific objects or people an average of 1.8 times over the 5 total sessions. So it's a little low, which I expected for baseline because it was made clear before the project started that this was a skill that he had not acquired. During the treatment phase, using full physical prompts were faded to partial physical and eventually verbal, and his average number of correct responses increased dramatically to 6 over the 5 total sessions. So it went from an average of 1.8 to baseline to an average of 6 during the treatment phase. With the removal of any prompts, the average number of correct responses from Chris increased slightly to 7.4 over the total 5 sessions. So to go back clearly, baseline 1.8 times, treatment phase 6, and then in the maintenance phase with the removal of the intervention, he had an average of 7.4 correct responses over the total 5 sessions. So the results of my project did suggest that imitation, in addition to prompting, both increased the frequency of sessions in which Chris correctly imitated his coach pointing at specific objects or people. This did support previous research that did show positive outcomes in relation to pointing cues and visually cued imitation training. Because the positive results were maintained in generalized settings such as different classrooms, there were times when he was outside and amongst different stimuli, it suggested this skill could possibly be generalized to Chris's home and community settings. There were a few limitations to this study, although I did establish IOA during all 3 phases. In the cases in which I was alone with the client, the correct or incorrect response was subjected to my own judgment and whether I believed Chris was pointing at the same object or person as I was. Another limitation in the study is that it was not established whether the object or person that Chris was pointing at acted as a potential reinforcer, which would motivate him to make the correct response more often. Future research in this area could consist of running similar trials and doing a similar type of intervention, but with a verbal child, to show how results would differ, since my client used sign language as their main form of communication. Another area in which this could be researched further would be pointing with peers, to have a peer prompt him to point at certain objects or stimuli and see if it increases his joint attention to a particular object. So that's my project. Thanks for listening.